So the dialogue went from there, and we outlined a number of our shared struggles as we all work to implement, sustain, or create new community-based health programs. And among other things, there were issues with regulatory compliance within states. There were issues that we heard about recently in DC, like measurability, scalability, reproducibility, and standardization. And we came up with a framework. And so this is a very vague concept, and we think that it makes sense, but maybe we have it wrong. So it starts with the community needs assessment. The needs assessment feeds inputs, outputs, and outcomes. So assessment, resource, activity, event. This is a pretty standard logic model. And so the questions that are asked at each level: what are the health needs? What are the service gaps? What do we invest? Who are the stakeholders? What do we do and who do we reach? What are the results, and how and when do we measure? So there's a variety of validated community assessment tools that are already out there. There is the city-county public health tool. There's a community paramedicine evaluation tool. The CDC has a number of tools. So the principles of community needs assessment are already out there. They're well validated, and we have some of that expertise in the room, and we can maybe talk about that afterwards. Again, this is sort of identifying who the players would be, who the stakeholders are, and what resources are available. We came up with 12 core components that we think that are foundational in having a successful mobile integrated healthcare practice: medical direction, the capacity for community assessment, strategic partnerships, patient-centered access, communications infrastructure, a call center of some sort, telepresence technology, the capacity to navigate patients through the system, a set of healthcare providers, and again, that's something larger than just EMS providers, transportation for mobility, integrated health record information exchange, sustainable funding, and the capacity for measurement. Example services, again, this is not meant to be an inclusive list. This is just examples. So fall prevention, immunizations, CHF, in-home care, hospice, diabetic care, mental illness, substance abuse, advocacy, patient education, treatment, prevention, navigation, and coordination. And this was sort of the schema that we thought helped conceptualize how EMS fits into a mobile integrated healthcare practice. So the idea is that at the top, this is the patient's experience, and it's cyclical. They have an event, and there's things that happen before the event, and there's things that happened after the event, and there's an opportunity to intervene along that entire continuum. And so when someone has an event, and we could call an event a preventable fall, we could call an event an acute exacerbation of a chronic disease, define it how you will, there's an opportunity to intervene before and an opportunity to intervene after. And certainly right now, when that event actually happens, EMS is who they call. And so the spectrum of providers that are able to intervene prior to the event and the spectrum of providers that are able to intervene after the event are much greater than EMS. Certainly EMS still has an opportunity to influence the patient's experience pre and post, but there's a lot of other players at the table. So the idea is, could you develop a interprofessional team that could work collaboratively to navigate and coordinate care across the entire spectrum of a patient's experience? So this is the logic model sort of all put together, and again, it's meant to be very high level, sort of 30,000 foot view, but it's a very simple framework for looking at these problems. The last piece, which was the performance dimensions, and we've all probably been asked or thought about what are the standard measures of performance for this type of a practice. And we're having similar discussions in traditional EMS care. And certainly there are opportunities to develop standardized patient satisfaction and patient experience measurements. But when every program takes on a different community health need, it's hard to have a standard set of metrics that can be used universally across all those programs. But perhaps, like the Institute of Medicine did, there are a list of dimensions or domains, the things that are thematically important to measurement in this type of a practice model. And this, again, isn't meant to be an inclusive list, it's meant to be a place to start a discussion.